Good afternoon, everyone.
Matt, how's it going?
What's happening? Sarah Worthy,
Hey,
how are you?
Sarah.
Hey everyone, thank you for having me, Matt and Tom.
Yeah, yeah. Any pleasure's ours, man. I can't wait to break into this a little bit. Interestingly, we don't talk. We talk to a lot of practitioners, right? People that are like, we've said it a bunch of times. They're like the wounded healer type, right? Like people that have gone through a thing, figured out the thing, and now they're preaching the thing and fixing the thing, and they got a tribe around that. Yours is a little different, and I'm excited to kind of peel that open and figure out, what goes on there. So I'm excited.
Absolutely. Well, if it helps, in college before I changed majors, I started as pre-med.
Yeah.
I thought I was going to be a
As did I.
I thought I was going to be a researching physician. Turns out I have a lot of sensitivities around cutting into live animals, and so
So that
found
wasn't
my
on your
path
dance
to
card, huh?
Yeah, and at the same time, I was really into computers and the internet was being created in front of my eyes, and so I hopped on that bandwagon and haven't looked back.
You know what's really funny? Do you know what my degree was in? Figure drawing, like literally
wow.
drawing naked people.
Wow.
I was also watching the internet explode in front of my very eyes and decided that drawing naked people is not going to be the future for me. So internet, here I come.
And we got AI for that now, so that was a wise choice.
Actually, I don't know. It's funny. We were just talking about this. AI is still reticent to do anything that's nude. It's not impossible, but it certainly is not
bashful.
It's bashful. Yeah, it's super bashful. Right. Yeah, it's cool. We could talk about like anything else on AI, but show me a penis or some boobs or a butt. No, can't do that. We could talk about anything else.
I feel like the 12-year-old version of me, that's all I would be doing on AI.
Yeah, sure. That's what most people want to do on AI. Yeah. All right, Sarah. So talk to us about DoorSpace. Like, first of all, you didn't just wake up one morning and do this. What happened? How'd you get there?
Oh, absolutely not. Although wouldn't that have been nice if that was how easy it was? So when I first started working on DoorSpace, we actually were more in the general sense. It came from the idea of managing my own professional credentials, my development. I am among that generation of people who has not spent a career in one place expecting a gold watch. I'd go in, I'd work on a project, I'd be there for a couple of years and then find that if I wanted to move up, if I wanted to develop new skills and do more interesting projects, I had to leave and go to another company. And so, you see a lot more people in the digital and technology space where every 2 to 5 years we're moving on to something else, because that's how we gained the opportunity to learn and grow in our careers and our development. And I realized that the way that companies are managing employee data, the way we see these employees who are looking for growth, for learning, and for acquiring new skills, all of that was converging. And this was several years ago now. I mean, you look around at micro credentials and online training and, understanding that every job, you're either constantly learning what's going on or you're going to become irrelevant very quickly. Today we're seeing what I saw on the horizon back then. And I just thought we needed a better way to track this information, to use this data on our professional careers, particularly on the business side. Businesses are collecting so much data on us as customers. We all hear and know how they know everything about us. And yet when you look at what they're doing with employee data, they know very little about the people who they've hired and trusted to deliver on their products, their services, to align with their mission and vision. And yet they're not really looking at that strategically. And so DoorSpace really came from that background. But then, of course, you look into healthcare, and it's 100 times worse in healthcare today than other industries, in large part because of all the regulation, the fact that in every state a physician needs a license to practice. So as we've expanded our globalization through these digital tools, we've made it much more complicated for the healthcare industry to manage their workforce. Because if you think about it, if you're a telehealth company, a staffing company, you have to now really be careful about tracking, is that physician licensed in 30 states?
Right.
because those are the places where their patients are being treated through that digital solution.
Yeah, and it's funny, we're working on this with a client right now. That sort of trickiness of jurisdiction is an interesting nut to crack. And so I'm assuming that you're at least through that lens, you guys are probably infinitely more valuable now, that telehealth is like a thing.
Absolutely. And it's a place where we see a lot of opportunity there. And again, with the staffing in healthcare, when they need specialists, we saw during the pandemic the rise in the travel nursing. And a lot of the travel nursing, they're actually staying close to home and just doing more of a PRN type contract work. But there are also a good large number and growing of nurses who they want to travel and get paid to do so.
Yeah.
And so they're going from state to state and working there for several months. And in that process, these organizations are having to manage that credentialing and privileging. I think everyone who listens to you probably knows a little bit about various aspects of healthcare, and certainly your clinician audience understands payer enrollment management.
Sure.
You're one practicing clinician, and you've got 50 to 100 networks that you have to manage. It's just an impossible burden, but it's an exact place where technology can come in and really be a huge lever to getting things done.
Sure.
Both on the, whether you're, a private practice with a few physicians, who's doling this off to somebody, just keeping up with it can be a challenge for when you have to submit all that information. But if you imagine once you're a hospital or staffing agency, when you have 25, 100 clinicians or more, every one of them has their own unique requirements that has to be managed. And we're building those tools to automate and collect that data underlying it. And then we're connecting that data to help go beyond just checking those compliance boxes, because that's really the core problem with all of this. And we can't go around and change all the state laws overnight. That's I think if you just look at when legislation calendars meet and how long it takes, that's probably a 20 plus year battle to fight to get some of these laws changed and reduced. And I think we all want our doctors, our nurses, and other professionals to stay on top of their training. But the continuing education right now, all of this money and time is going into making sure they meet those requirements and checking that box of numbers of hours, but they're not matching it to what types of conditions are my patients seeing, what new treatments are relevant to my specialty. And clinicians have to...
Right, it's just a generic one size fits all.
Yeah. And clinicians, like, especially when you talk to, if you think of anyone who's in healthcare, these people, they care, they want to go in and do a good job, and they want the challenge. You don't get through medical school, nursing school, you don't get through those processes if you're not hardworking and enjoy a challenge and really passionate about what you're doing. There's the rest of us who give up earlier,
Yeah.
We find our passion somewhere else. And so I think we do a real disservice by then saying you have these 50 hours every year you have to take, but we don't care what those are. Just check off that box. Right. And so by leveraging this data that is already being gathered to check off that box and putting it through our solution, where we're building in predictive analytics, machine learning, and different AI tools to analyze and to start looking at, here's what the EHR, the types of patients they're seeing, here's where we're seeing they could improve against benchmarks, here's CME that meets your requirements and trains you on that specific condition. And we just serve it up to them. That's our vision over the next year as we're growing with this data, so that they're not having to spend that time. Because if you talk to the doctors, nurses, other clinicians, they would love that. They don't like just checking that box. They want that time learning to mean something, but they don't have the time left over to do the work. And so we're putting technology to work to use this data and really help both individuals and the organizations that are employing them more strategically develop their workforce in alignment with the changing patient populations that they take care of.
What's interesting about what you do is my quote unquote day job is we build technology, right? So, and we build it for all kinds of people. And when I hear these stories, I can't help but to look and say, it doesn't have to be this ridiculous. Like, there are so many options to not make this crazy.
Yeah.
But then when I think about it a little bit harder, I'm like, you know what though? It makes a lot of people a lot of money to be this ridiculous. Like, right. Like, and so like, I feel like where you have a startup that might be, you know, if you were to go to a startup, right, that just got $100 million in funding and say, we're going to actually just light 50 million of it on fire because we just don't need that. You know, like, I think you'd be like, are you crazy? Like, no, of course we're not going to do that. We're going to build a system that won't do that. But if you do that in a healthcare situation, like, yeah, that's cool.
It's almost rewarded. Yeah.
Yeah, right.
But I love what you said about like, you know, look, I'm an acupuncturist, so I don't have the level of complexity in my practice as an MD, but you know what CEUs I take? The free ones.
Yeah.
The free ones.
Yeah.
Why?
The
I don't care. I'm never doing facial acupuncture, but sure, that's a free CEU class. I'm going to do it.
It was sent to you when you needed it. It met your requirements. You checked out.
Exactly.
Right.
Exactly.
And I'm sure that there are free or low cost and interesting classes out there that you just don't know about and you don't have time. So you just take what's been delivered to you.
Exactly. What shows up in the inbox when I need it for the, you know, the recredentialing or licensure or, you know, my state or federal organizations. Yeah. Here you go.
Yeah. And it's that education is across the clinical board. If you have a license for the state or states that you're practicing in, you have continuing education mandates. And then you usually have some sort of board specialty that you're a member of that has their own continuing education requirements. And you have to align with both of those on a regular annual, biannual basis, or you lose your license.
And I'm assuming that's not universal, right? There's not parity across all 50 states for medical
every
doctors,
state
right?
is different in what they need from whether you're an acupuncturist, if you're a nurse, even what you can do in terms of the types of treatments you're allowed to see when you're nurse practitioners. And so it's, again, at the organization level, it's just chaos. And if you talk to any organization that's managing a clinical workforce, every one of them, they know that they have missing expired documents. They often don't even know what. We know our data's a mess. And they're spending hours trying to find certain documents over and over and over again from these shared drive systems.
Yeah, what a waste of time.
Nobody has really gone in and used design principles on this process. And that's really, I think, the differentiator is we've gone in and mapped out every step from all the different types of users in the system. We haven't looked at just a physician side or just a hospital side. We've done pilots and are working with customers that are in the hospital side and the staffing side. Talking about if they're doing practice, urgent care. We've really worked hard across the spectrum because no two journeys are the same for these clinicians, but organizations really need to be better handling that. Yeah.
Now, is your customer a hospital or is it a doctor?
So our customers are the employers, the facilities typically, or again, it could be a staffing group. It could be a physician medical group, right, where they're working on it. Now, in some cases, that is also a doctor, and we do talk to a lot of CMOs and CNOs in hospitals who are usually a champion in that process because they have to manage all of these credentials and certifications for their team, for their department, and are trying to track that on top of also, all the other responsibilities they have in that
doing
role.
their actual job.
Actually doing the thing that gets the bills paid.
Actually doing the thing,
But we do also have we're a two-sided marketplace in the sense that one of the unique things about our solution is that any clinician can sign up, create their own account, and they can start tracking their own continuing education credits, their own licensure. We have some basic starter credentials we ask for, like their driver's license and their medical or clinical license, the basics. And then we want to start giving them a tool that they can use from graduation to retirement. And our goal there is to continue to build out and get their input in this process. A lot of healthcare tools in the workplace are built without their input at all until it's implemented. We saw that with EHRs, and there were a lot of issues with user adoption and errors that were made from not understanding and the tools not being intuitive enough. And so we want their input, but we aren't selling or advertising their data. We make it very easy for them to put stuff in, to get it out, to get reminders when something's coming up. I don't know what you use, Tom, but when we talk to a lot of clinicians, they use like their email inbox, and they have a folder somewhere or a binder in the closet. There you go, your binder, right? Right.
And I just pray that I get more than one email. Or I'm walking down the hallway and go, oh shit, that expires at the end of the month. Right. And I'm looking at the plaque on the wall or something.
Yeah. And so we really want to build this as a tool that individuals see the value in saving time and being more organized, because there isn't an app for this for some reason.
Well, I'll tell you exactly why that happened, because the EHR world was run by venture capitalists or private equity guys or people that were money people, and they, of course, want the cheapest products, so they go overseas. And this is what happens when you have developers designing, and I use that word in the loosest sense of the word, right? When a developer is left to design, and this is how, and I've given this talk before. I've told clients this 100 times. I said, what drives me crazy? What is the expiration on your credit card? Right? Like it's always the same. It's a 2-digit number followed by a 2-digit number. Like that's what's on the back of everyone's credit card. Sometimes it's a 4-digit number, but it's usually like month, year.
Yeah.
Why the ever living fuck would the form on a checkout have the word January on it when nobody fucking knows what that is? Yeah. I know it sounds stupid, but like everyone knows that January is 1 and February is 2, but they don't. When they're
once you go, like, what's May? Is that 4? Is that 5?
Yeah, right. You're like, fuck, I gotta go May, April, and
August and September are the ones I'm always forgetting.
Oh yeah, well, no,
I don't know why I know those two. Maybe it's because I got kids getting they go back.
But when you have a developer who's basically like, what do you mean? January's of course number 1. This is fine, and they're not wrong. It's fine. You'll eventually figure it out. But if you're looking at system design and product design, and you're saying what is going to be the easiest thing for a human being to actually function with, it ain't that, right? Like, and so the reason why, in my view, is like the product was making money selling these systems to hospitals. The product was not making it good.
They're also the promise they sold all of us on was like, hey, Tom, you're going to be able to log in to your EMR, and you'll be able to get the notes from any hospital. You'll be able to. They'll all integrate. They made 1,000 different EMRs,
right? That precisely
don't
zero
talk
of them
to anybody. And it was funny. I remember when I was the director of this chain of wellness centers, and I probably shouldn't bring that up, but we're there now. And they called us into a room, and they're like, "Yeah, we bought this EMR." We're like, "Well, did you got like 12 different healthcare practitioners here? Did you at least run it by
anybody?
The medical director?" No. We bought the most expensive one. It's the best. And we're like, did they? Who told you it was the best? It was the most expensive one. And then literally we had somebody on staff
what I'm hearing
had to go there and try and program the fucking thing to do what we needed it to do. And she didn't even work for them.
Yeah, right. No, I feel like what I'm hearing is we're doing this wrong. We need to charge more money than everyone else. And then
I mean, look, that's what Peloton did.
Yeah. but like, Sarah, what you've hit you've hit a nail on the head here, in the sense that, like, that's not one of those. First of all, the barrier to entry in that is steep, as no one needs to tell you, obviously, right? Like, it's a big industry with a lot of moving parts. A lot of people don't want to lose their ground. I can't imagine how difficult it is to operate in that theater. But like, even if you could, most people are just chasing the money, right? Like, it's not really about making good shit. So like, I love that you're doing that, because like in my mind, I'm like, well, duh, why wouldn't this just be the case? Right. Like, and I'm a big I want my technology to be completely opaque. Like, I don't want to know it's there. Like, I just want it to do what it's supposed to do, and I don't want to have to interact with it. And so if I was a practitioner and I had something coming up, I just like a calendar, just put a fucking calendar reminder on. I'd be like, hey man, you know what? You got 6 months until this thing is over. Here are your options. Like, I don't want to have to think about it. Like, I just want to,
I know, I totally get that. I think the problem is it's not just one or two things, right? It's not just the state license, right? And different requirements under all of them. I think what Sarah is kind of like, I'm like, wow, this sounds really good as a practitioner, because I'd want to be registered with them because I'm immediately more marketable to other clinics.
Sure.
Right, here's all my shit. Here, I can send it right to you. Hell, if you're a member of that, you just log in, you can find it.
Exactly. And that's where we want to take this, is really make this data interoperable.
Sure.
It's funny y'all bring up EHRs. I mean, first, EHRs were never meant to you, and none of them that I know of are tracking employee data. I mean, we're really more an HR and compliance on the workforce side of the business. So when we want to connect into EHRs that are tracking outcomes and pull the outcome data per clinician in, not any patient information, but just, if they're seeing a dozen patients for a certain type of surgery, how did those quality scores for the surgery and those costs come out? Are they different than they were last year for that same surgeon, and so forth? What can we learn in terms of the outputs of how they are performing that are beyond just financial numbers?
Right.
But the EHR conversation, I mean, y'all are very spot on, and I hope more people in healthcare will hear this and allow themselves to let go of the illusion that has been presented to them, because we have all of this AI being marketed in healthcare right now, and I love AI. We use AI in our product because, to your point, right, you want to be able to take a picture of that license, and our system tracks and reminds you when it's coming up. You don't want to have to enter a bunch of more information and tell it your expiration. I mean, why even type 1, right? Our system just pulls the expiration date right off that chart.
Right out of it.
Yeah.
We know now when it needs to be renewed, and we tell y'all 90 days in advance, and then we keep reminding you until you do it. So y'all don't have to think about it. That's what we want to build out there. But these EHRs, they were designed specifically for finance, and they were designed to track data. And so a lot of organizations in healthcare, EHRs were really their first introduction at a more in-depth level to data operations and data management in an organization. I've been working on the customer data layer in businesses almost my entire career. And it was terrifying me. I was actually a consultant brought in on a couple of different, I have contracts, can't tell you their names, but y'all know the company, the ones that are out there. One of them got acquired by another one, but it was still big enough. But in both of these consulting, they brought me in to be that voice of the customer, the patient, to talk about it and think about how they were going to be, because it was going to be collecting all this data. And they just simply didn't want to hear any of the arguments. They were dead set on making money. I even heard on more than one occasion the phrase is, well, these people's lives are on the line. They'll pay whatever we charge them. Right. And they wanted that data to be trapped. So if you went to a hospital, say you were on vacation with your family in Florida, I'm in Texas, so if you're in Florida, this analogy may not work as well, but bear with me. And so, but so you're on vacation in Florida, you get injured, you go to a hospital there, right? You are not going to go back to that hospital for your follow-up.
No.
6 weeks later, you're going to go to the hospital in Texas, right? And I would bring up these scenarios because they were like, well, but if we lock the data in, that'll draw the patient back to see this hospital. They won't go to our competitor hospitals, and it's a value add. And that kind of thinking to me just made no sense in the context of healthcare.
Sounds like some hospital execs need to meet Luigi.
Yeah.
Sorry.
Yeah, I mean, seriously, that is the most backwards.
Did I just get a terrorism charge?
Yeah. I heard nothing. Y'all may want to edit that part. I don't know.
Nah, let it fly. I shat on America last night. It'll be fine.
This is the most backwards situation, though. I mean, because like that, you're right. Like in no world whatsoever am I going back to that hospital in your example. Right. Never. Okay. Right. Like I might not even go back to Florida ever again. Cause like maybe I was just going,
I mean, there's sharks when you're surfing. He wants sharks. I don't know what the accident is.
It doesn't make any sense at all to do that. Like, and I guess what I don't know what the metrics are on that use case, but we might consider that an edge case in software design.
I would say that's worthy of it because like you could have a massive accident. You're not going to go to the hospital for like, I got a little scratch. You're going because something bad happened.
Right.
Yeah.
Broken, sprained something, at a minimum.
Yeah.
Yeah, exactly. But I'm certainly not likely to go back there. Certainly not for a follow-up, right? Like, I mean, I might be still stuck there because I'm in traction, but like, But that's the only
otherwise
version.
you're going back home, right?
Yeah, correct.
Yeah, absolutely.
And honestly, even if I was in traction, if I had to be in the hospital for like a month, I would figure out how to get the fuck get back to my house, right? Like, I mean, my priority
How do I transfer? Yeah, to
how do I
my
transfer
people
to get back where I'm comfortable, right? You know, we're in Baltimore and we've got some of the best hospitals on the planet a mile from my house. Like, if I get hurt in Florida, I'm coming back here.
Right.
Exactly. You know.
Well, and most of us have jobs to come back to, right? We can't spend, we can't take a day off to fly back out to Florida to go do our
it's insane. But that's the kind of like short-sighted, dumb thinking, like, that doesn't make any sense. And like but if you think about it in a vacuum, it sounds impressive at an executive level. We're going to trap the data here. It's a value add because it brings people back. And I'm like, but think about what you're saying, you dumb shit. Like, that's not at all likely to happen, period.
Well, I think, we've seen the same things with non-compete agreements being pushed onto physicians in particular, so that they can't practice if they leave that hospital system and want to go work for a competitor.
Yeah, that's real tough to enforce in Maryland, by the way. Like, non-compete.
You absolutely can't. Yeah.
It's Maryland has a real aggressive stance on non-compete. You can sign them all you want, but they're basically worthless.
Well, and more states are, and I think even at the federal level, they've started evaluating and looking at how they can remove these. I think there's still some question about where that stands at the federal level.
Like, I've been practicing doctor for 25 years and I just want to go to a different hospital, but I can't. But you're, by the way, good at nothing else.
Exactly. What else are you going to do with that medical degree? And so there's a lot of grade that happens, and but there's also a lot of business value what we're doing. And when I think about the money loss, like they got greedy and short-sighted. They wanted those immediate hits of what they could do, but they didn't think about how this would impact the greater system and the cost to that. And I think we've seen that overall, EHRs have had to have a lot of work done on them to where they're actually starting to not cost these organizations more money than and start delivering real results on them. I don't know all the data on the EHR market today, to be fair in this, but I know it's been a long road, and a lot of our customers, a lot of the people I talk to day, they still feel like the HR takes more bandwidth and more resources from them than their old charting systems. And so I think it's really important. Technology is brought in that adds value. And meanwhile, on the way that they're managing this workforce data, not only are they interrupting their revenue cycle, if especially in these hospital environments where there's a lot of commercial payers and Medicaid, Medicare payments, if that provider falls out of enrollment, if a license goes, or a certification that's required for what they're doing, if that expires that day and they see a patient the next day, those payers are going to deny those claims. And if that certificate is up to date, but it's at home in the payer's mailbox, in the clinician's mailbox, but the organization doesn't have it, then that payer is going to deny that claim, and they're going to have to rework it. And that could be months of delays, if ever, getting paid for these claims. And that stacks up in these larger hospitals where they're processing, because if you think about it, that clinician has that requirement for 30 different payers.
Right.
And so it really adds up when they don't have this managed on the revenue cycle side. And these are requirements that have to be done before they can put that clinician in front of the patient. But then I think there's also that overlooked side. And this is just something I've noticed across American culture, not just within healthcare business, but in other industries too, is that we seem to have forgotten about employees as being human beings in the process. And I know, but when I look at how businesses are using their data, they don't look at employee data in that pool. They don't see it as being one of the data pools that we can bring into these equations and understand, if you hired 10 new nurses who are all, maybe half of them just graduated from different nursing programs and the other half have various levels of skills, how do you onboard those 10? How do you look at what experience and skills each of them individually has? If you put all 10 through the same onboarding program, and I hear about this from we have a physician executive who, of course, has umpteen years of experience treating patients. And a couple of years ago, he went to go work at a new hospital, and they put him into this room for a few days of just watching these generic videos that everyone else has to watch that he has seen at 2 other places he worked at. That, starting them off on the job and then in the day-to-day, giving them all of this nonsense HR onboarding, training that doesn't impact their work, doesn't help them be better at treating patients and about doing what they want to do in their careers. That is all a direct factor to having that burnout, having that increased frustration, that turnover. Particularly with the physicians and more the nurse practitioners and in physician assistants, because they have
more face time.
They have the most burden of seeing patients as many as they can, and their compliance work and their payer management is the biggest stack of paperwork, and they're having to spend all of their nights and weekends on this auxiliary work that could all easily be automated, and that data could be brought into the equation and utilized by that business to help the business better understand how to train those employees in the right way for their individual needs, how to help managers and leaders know who their people are, know what their employees are doing in terms of strategic planning and for succession, for hiring next year. There's things we can do there, but I think our biggest impact is if we can automate some of this and give that data to managers today instead of 3 months from now. They can go in and support their people. They can go to their new nurses and say, here, for you, we want you to train here. For you have some senior experience at these other hospitals, so we're matching you with this other nurse so that she can just show you the ropes here. Every little thing you do in those types of touch points, just like with our customers, using our customer data to personalize, hey, we saw you bought this, so we want you to also try this out because our data shows you'll like this too. Dear Jane is the email address to Jane instead, just those little touch points make the process more human. And humans need that. We all need to have that, and we need it in our work environment, not just in our. And in fact, I think it's worse, especially doctors and nurses. They generally have disposable income. They're out there consuming. You go out and you get this personalized red carpet rolled out when you're the buyer, and then you go to work and you get treated like, an admin having to do all this data entry all day. It's a disparate experience for them, and that increases their level of frustration and their disengagement with what they're doing. And turnover and burnout is costing these organizations far, far more money than
and here I am thinking about the patients going like, look, if the doctors don't have to deal with that bullshit, they're going to be more present for their patients.
Well, it's not just that, but like when I talk to anybody who's gotten a virtual assistant or an actual assistant or an executive assistant or any version of an assistant, right? Almost across the board, the first thing that people notice is like, dude, I don't have to phase shift ever. Like my day is just my day. Like if you're make cabinets, make websites, doctor, whatever it is, like I could just do that. And yeah, there's some administrative or some like sort of, overheady kind of stuff. But for the most part, like when I got my assistant several years ago, like just scheduling meetings, nothing else. Forget about every other task that I get help with. Just not doing that made me feel like I had like 8 extra days in my week. Just feeling like nothing to do with fact, just my own perception of my job.
Well, and that task switching, that's a cognitive load problem. And we talk about this a lot in UX design and psychology of how people interact with products, particularly on the online world. And, we talk about the drinking from the fire hose problem of the information era, right? So that's what you're experiencing. And it's something that is I think really different about my approach and how we're building out technology on our end. It's very different from what EHRs did. We're looking at how do you reduce that cognitive load, and how do we measure that so that, again, people aren't having to spend that mental energy dealing with how do I fill out this payer application correctly, or how do I get the right continuing education credits by this deadline, where do I fit it into all of that. When we have this data and we have it integrated in our system to use, we can build those automation tools, we can bring in the AI, the assistants. I just keep thinking about having a credentialing specialist AI where you can just ask them your payer questions for our admins, because there's just these little things that it's one extra thing on top of another extra little thing on top of another little thing, and none of it's what you want to be doing.
No. And so each time you do it, it's like a choose your own adventure book, right? Like, you get to one fork in the road, you're like, okay, I just have to make this one decision, and I got to go over here first. But then you get 5 feet later, you're like, shit, I don't know how to do this. Now I have to go on a research journey. So now I get like 3 more options, right? Like, and it's just all before you know it.
3 in the
you've
morning,
gone 10 feet, and you've had
Reddit forums.
Yeah, right, exactly. And now you realize that the next 3 days of your life are going to be consumed by this dumbass thing that you never wanted to do in the first place. That in your brain you allotted 8 seconds for, and now it's going to take multiple days. Yeah, I get it.
And there's not a lot we can do, just for anyone because we get asked this all the time, if we can automate the payer enrollments and things. I was like, well, we have our payers that we have to negotiate this with, and they have their own process in place.
Yeah, they have their own stupid ass book that you got to fill out and send in and wait 6 months.
Yeah,
it's infuriating.
Yeah, I've heard they have AI on their end to manage this, and I was like, we can build AI.
Yeah, they have AI to deny everything.
Yeah.
So we're going to build it so our AI talks to their AI instead of the doctors.
That's what everything's going to be eventually.
I heard the AIs fight. I heard the AIs try and kill each other.
Yeah,
that will be interesting. Maybe that will be our next opportunity after this is AI fights.
Yeah,
that sounds great.
So Sarah, where do we send people? How do we get people to connect with you? I'd love to sort of help you spread the word on this, because I do think it's cool. And as a tech guy, I'm biased, obviously.
Absolutely. So if you want to find information, if you're the clinician and you want to be one of our early adopters on our app, you can just go to doorspaceapp.com to create an account, or look for the DoorSpace app on the Android and Apple stores. Perfect. On your phones. They sync, so you can use the browser when you need to do a lot, and then your phone when you just need to get something in there quickly. And then finding me on LinkedIn, just look for Sarah and Worthy on LinkedIn. I should come up pretty readily. I think you guys will link to it. I try to be.
I'll hit you up myself.
Yeah.
You're real easy on there.
Yeah, come find me, talk to me, let me know what we want to do. I want to be talking to the leaders in healthcare who really get the importance of understanding their workforce at a more personalized level, and supporting that retention and development, and get off the recruiting, hamster wheel that everyone seems to be on. Because as soon as they're hiring them, they're leaving, and we need to stop that. We need to keep them and grow them. I don't know, cool. Tom, you'll have to contact me separately, and we'll learn all about acupuncturists, because I know y'all have a lot, but I haven't learned too much about it.
No, I'm more than happy to.
Tom's like, it makes my life easier. I'll be your guinnie pig, no problem.
I'm already on the website. I'm setting up an account.
Yeah. That's hilarious.
My favorite Simpsons episode was one where Homer Simpson just kept saying, "Why can't somebody else do it?"
Yeah. Oh man, Simpsons. We could go down that rabbit hole. Every time I use the UX argument, I think of the Homer Simpson episode when he's like, "I want a horn here, 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 here." It's like, oh man. Anyway, Sarah, thank you so much for coming. I really appreciate it. I look forward to seeing where this goes, because I do think that there's a lot of value that you guys can bring to like freeing people up to not have to worry about this shit, man.
That's our goal. Thank you so much for having me. And I look forward to hearing from everyone else who's listening, who wants something to make their life a little bit easier on this side of their job.
Love it.
Yeah. Awesome.
All right, guys. Enjoy the weekend. Talk to you guys soon. Take care.
All right. Thank you, Sarah.
Be subversive, irreverent.
Health is wealth, but you knew that.
Everybody knows that.
But so was following us on social media at Irreverent Health. And check out our website for more exclusive content at irreverenthealth.com.
Oh, I like this.
Thanks for tuning into this episode of Irreverent Health.